This lesson is about sickle cell disease. Let's talk about the pathophysiology of sickle cell anemia. This is an autosomal recessive gene, so both parents have to have this mutation to pass it down to the client. Now, this happens with an alteration in your hemoglobin. Either your patient is not getting enough oxygen or possibly not enough fluid. Let's look at the image on the right. On the left, I see a normal hemoglobin cell. It's nice and round versus what? That elongated sickle cell-shaped hemoglobin on the right. When this happens, they clump together and they can occlude in small blood vessels. So this can cause ischemia maybe in your hands or feet or even organs. What are clinical features of a patient in a sickle cell crisis? We can have a vaso-occlusive crisis, meaning that painful distal ischemia. Think about tiny little clots, hands and feet. We can see a sequestration crisis, so I'm thinking pooling of the blood in the liver and spleen, causing those organs to actually infarct. I can see a hyperhemolytic crisis, so marked anemia due to that massive destruction of RBCs. So what assessment findings am I going to find? When I'm thinking about vital signs, I'm definitely going to see tachycardia. These patients are hypoxic. They're going to have pain. Think about those ischemic limbs, definitely pain in the joints where things are clotting off, and possibly infection. They're going to have leukocytosis or WBCs over 10,000, and this can occur from infections or inflammation of tissues from that ischemia. We've talked about anemia from that RBC destruction and an increased reticulocyte count. So that means a bunch of RBCs, but they're babies. They're not ready yet. What are some interventions that we're going to do? Well, definitely diet. These patients need high protein, high calorie diet, in addition to a multivitamin without iron. Why? Well, think about it. Those RBCs are breaking down and putting a bunch of iron into the blood. They don't need that right now. Our patients need folic acid, and this is going to stimulate erythropoietin from the kidneys, which basically says, make more RBCs, please. We need to hydrate these patients, and this is going to be aggressive, both with IV fluids and oral intake. Remember, thick blood is sticky blood, and we don't want that. We need to do infection prevention, so we're thinking vaccinations. So we want to make sure they're up to date on all their vaccinations. We don't want to throw them into another crisis down the road. These patients need oxygen. Remember, they're hypoxic. We want to prevent pulmonary complications and keep them comfortable. Definite pain control, because remember, little clots everywhere. Hands, feet, joints, even organs. These guys are in a lot of pain and they're going to need around-the-clock analgesics. So more timed meds rather than PRN. The last thing that we want to think about is assessing our patient's tissue perfusion. Remember, they have little clots everywhere. So we're going to look at their labs for sure, but also think about assessment. Does my patient have a pulse? Are their limbs pale? Do they have pain? Great job, you guys. Sickle cell anemia is really hard, but I know you can do this.